G'day, my name's Ben and this is MedQuiz. So I was planning on doing a series of videos on on everything, all things paramedicine, all things pathophysiology and whatnot. That's time consuming. And this evening I was sitting here eating mango sticky rice and for some reason autonomic dysreflexia popped into my head. So I figured we will do a video on autonomic dysreflexia. I will do a pathophysiology video on this. It's going to come out very, very soon. And by very soon, I mean as soon as I get a chance. But for now, let's run through a simulation on what we would do from a pre-hospital perspective. So, as you can see, we're in the simulator here. We've got autonomic dysreflexia checked. Hit save. And we'll jump into our member simulator and go new scenario. And we are called to a 34-year-old male with autonomic dysreflexia. That's specific. Sometimes it may be that. And interestingly enough, my experience in going to autonomic dysreflexia cases I've done too, have been that both patients have known something's up. Both patients have known that it's autonomic dysreflexia. As you'll see, it does present with generally obscenely high blood pressure, and we will go into more details about why that happens as we go through the scenario. But rather than sitting here and talking my way through it, let's crack on. So, we're on scene, on arrival. What is my windscreen survey? Neat single-story house, clean, tidy, and well kept. I added tidy in there myself because it doesn't actually say that, but it is very early in the morning, and I finally got both children back to bed. What is the... Oh, we need to ask about danger. Oops. Partner or patient. As you can see, I am on placement at the moment. I've had to trim my beard down to something a little bit more mask friendly. Been an interesting couple of days. Excellent. And what is the general appearance? I will start using the buttons at some point, especially since I can't spell. My impression. Patient appears comfortable in a seated position, flushed and diaphoretic. Now, interesting, and we'll go into all this a whole lot more. The flushed and diaphoresis is based heavily on the fact that your autonomic dysreflexia, and we're diving into a little bit of patho here. Basically, it's a complete block or complete break in around the T6 vertebrae. So we can't see messages going down or back up in that sense. So what that means is our sympathetic and parasympathetic nervous system, where they're usually at odds with each other and sort of balance each other out, they can no longer do that anymore. So we've got some sort of stimuli from the lower half of the body. That can be anything from catheter issues, bladder, bowel issues, right through to pain or some other sort of discomfort. So your body's trying to send that signal up the vertebrae, up the spinal cord, trying to say, hey mate, I'm in pain, do something, or I'm uncomfortable. The message is getting stopped there somewhere, so it's finding another. To my mind, and there's a lot more pathophysiology here, but to my mind, the easiest way of describing it is its body knows it can't feel pain, or body knows there's something wrong, and it's like, I can't tell you because I can't reach the head, so I'm going to do something else so that you know something's wrong, down here. And that will come out through a strong activation of that sympathetic nervous system. So your fight or flight response is going to kick off in the lower half of your body. Now your upper half has its parasympathetic kicking along. It's chilled out. It's like, yep, living the good life. But then suddenly something's happening and it's like, oh shit, something's happening downstairs. don't know what's going on, but let's just chill out and try and relax a little bit more. So what tends to happen is your blood vessels, particularly around your face, they dilate to try and bring that blood pressure, because obviously the sympathetic nervous system has is causing your blood pressure to skyrocket. So your parasympathetic nervous system is like, come along, chug along, chill out. So it dilates the blood vessels to try and bring that blood pressure down, to try and do that. It also slows the heart rate down. Basically just trying to counter that and keep that homeostasis and just balance everything out. Doesn't generally work because the messages, T6 is here, message ain't going down, just calm down, message ain't going up to elevate things. So as a result, we end up getting usually a slow heart rate with a high blood pressure, flushing, sweating, because we're activating all these different nervous systems. And it can be quite dangerous because the blood pressure up, it's not uncommon to get, 180, 200 and higher. So it's quite an interesting one. And obviously these people are generally quadriplegic, or, they've got that blockage at the T6. So there's a complete disability there. So they often can't do a lot of things for themselves as well. So it becomes quite challenging. That said, a lot of people do know what it is in that position and do know, the issues. So now that I've rambled for a little bit, we'll crack back on with this scenario. Need a partner name. Hello, it's Ben and John from the ambulance. And what's happening? Often those people also have carers. Yeah. Okay. And in this case, look, I thought I'd just smash it out there and see if we can shortcut a few things by asking if the patient knows what it was. And he says he has no idea. So, okay. No problems. Look, I do backspace a lot in this because I don't like making false promises, just as I wouldn't in real life. I wouldn't rock into a patient that's having any sort of episode and be like, yeah, look, let's get this fixed, or hey, we'll investigate this, hey, we'll figure out what's going on and get you feeling better. I'll never promise anything like that because I can't deliver that. I mean, obviously I can do my very best to investigate, I can do my very best to try and make them feel better, but I'm not going to make a promise when I don't know what's going on. I mean, it could be a mental health thing, and they're completely unwilling to listen to a reason, and boom, I've just lost all my credibility because I've said, hey, I'm going to help you, I'm going to fix it. When reality is I may not be able to because it needs to be a teamwork thing. So yeah, similarly in the simulator, my brain goes faster than my brain. And I really wanted to what I wanted to do there was actually get the vitals going. What was his name? John. Awesome. So let's go vital signs survey. I don't know if I fixed this up over here. Pretty sure I have, but we'll see. Let's assume he's got, all right. He's spoken to us, so he's got an airway and he's breathing. And we've just felt the pulse, and let's say it's good. He's talking to us, so it's going to be good. Can you tell him what I want to do is ask tactfully if there's a quadriplegic. So yeah, we are starting to see, we are seeing very much a autonomic dysreflexia thing here. We don't have, blood pressure hasn't come back yet. -42. So we're elevated. We're not as high as we've seen. And heart rate 38 BPM. That's really low. That's concerningly low. SpO2 92. These will update, I'm sure. Blood pressure isn't as high as I would have expected in an autonomic dysreflexia case, but we will see if that elevates further. And again, that's also the reason for our headaches. This patient reported headaches, and generally they'll get a headache, quite a strong headache, because we're seeing blood vessel dilation and high blood pressure. So we just got blood hammering through the head there. It's it can't be nice. Let's just see if it comes up in the history. So we've covered off paraplegic. Okay, so excuse me, it is almost 2 a.m. here, so I'm a little bit tired. It's been a long few days. I just come off a run of nights, which would make you think, well, I should be less tired at night, but it does not, unfortunately. Okay, so we've had to do a little bit of questioning here, and that's not uncommon actually. But he said his belly hurts. Says that the catheter's checked regularly. That one was put in recently, and we've finally drilled down any changes in the urine colour or smell, and it's smelling bad. So we're starting to go down that UTI pathway, and that's a really common cause. Usually catheter issues, UTIs, things like that for these autonomic dysreflexia cases. Very much based on, there's a lot going on down there. There's going to be pain, swelling, inflammation, infective process basically. The body can't feel it because it knows it's got the T6 issue or the paraplegia. So the body's letting him know through that that nervous system response. Blood pressure's still 142. I think that's what it was up here. Yeah, 142 on 85. Heart rate 75, SpO2 is 97. These for some reason aren't updating. They should be updating every time. I will fix this. Okay, cool. So look, we're going to kick off with some Panadol. There's probably no harm in giving some morphine. Look, it's a headache, but as you can imagine, we've got blood vessel dilation and a thumping headache there. So morphine potentially if Panadol really doesn't take the edge off, and if he's complaining, if it gets like, if you're saying it's like an 8, 9, 10 and 10 out of 10 pain, we'll probably go down that morphine pathway, but I'd prefer not to because it is a strong ass drug and he's only got a headache, but there's a lot more at play, so we want to try and get him comfortable. The morphine would also drop the blood pressure potentially a little bit, which wouldn't be a bad thing. Not that it's super high at the moment. I'm quite comfortable with where it's at. When it starts getting up into the 200s, that's when it's quite scary. But for now, we'll get to 1 gram of calcium. Fantastic. Okay. Look, we'll kill bananas. All right, we're in the ambulance. All right. Alright, skin's really done. Let's just get our proper rubs back, because we never got a BGL back. Blood pressure's coming down again, that's quite good. BGO's good, temp's good, 97's good. Heart rate 68, it's good. Look, as far as we're going, I almost don't even know if this is autonomic dysreflexia, because generally autonomic dysreflexia, we're starting to see really high blood pressures. So yeah, that's a good one. Treatment pathway is largely symptomatic. We're going to be looking at, if the BP is too high, we're going to look at GTN to bring the BP down. If the pain is really bad in the head, we're going to offer analgesia for that. Oxygen, things like that. In this case, it's really going to be rest and reassurance. Get him into hospital, get that catheter checked, get that, whatever that noxious stimuli is, which it does sound like it's going to be the catheter, managed. All right. I think I'm happy with that. So, autonomic dysreflexia, complex condition, careful diligent monitoring, including examination for potential causes, seeking to identify early signs, while providing a safe and effective environment for the patient. Correct treatment and management was provided. Patient handling appropriately considered. Well done. Yeah, look, that's pretty much it. It is a complex condition. We're looking at things that our patient, unfortunately, might have an idea on what it is, but they can't fix themselves. They can't really manage. Whether that's catheters, whether it's tight clothing can cause issues. It could be a spider bite. It could be a range of different things. So, yeah, it's just going to be a case of managing that. So, yeah, look, that was a very simple case. I'll, throw in the cases that I went to over the last sort of 12 months. One was a irritable bowel issue, of all things. It was the patient had some diarrhea, unexplained, probably just a gastrointestinal bug brought in by the carer. That was leading to some loose stool, and potentially that could have been, how do you say nicely, when you have a lot of diarrhea, it can irritate the anal sphincter. Let's just say ring of fire sort of thing going on, just with the force of the bowel movements and things like that, some irritation. We suspect that was what was the cause of her noxious stimuli, as they call it, and that was not something we could help with. So once we sort of identified it, the patient, in similar to this case, by the time we got there, her blood pressure had gone down. We sort of tracked back, looked at a history on a BP machine, and it had been up quite high in the high 100s. But given it had come back down, we sort of determined that we didn't need to transport her. She was managing well. She had a carer there for the day, so there was no need to really do much there. The other case we did transport to hospital, and that was a catheter issue. I believe it was a blocked catheter leading to a urine backup. The patient's bladder was there for sort of saying, hey, I need to pee. But due to the catheter being blocked or kinked or something, I can't remember off the top of my head, wasn't able to expel that urine, banked up. The bladder was, obviously trying to send that signal and wasn't able to due to the block in the T6, where the paraplegia has occurred. And we couldn't identify that. We couldn't do anything with the catheter, so that one needed to go to hospital. We used a hoist that patient had a hoist built into their bedroom. We used that to get them onto the stretcher and transported them up to hospital. I would assume that they fixed up his catheter probably quite quickly, which would have seen everything come down. That patient we did use GTN with. So it's just it's a little red spray, glycerol trinitrate, goes under the tongue, causes a vasodilation. and venous pooling to try and bring that blood pressure down. Autonomic dysreflexia is a little bit of an interesting one. Do we really want to be causing vasodilation when potentially we already have cerebral vasodilation? It's going to be up to your local procedures. Ours in Queensland, it was around having the BP in a certain range. Having the heart rate in a certain range in the BP as well, because we don't want to be giving GTN vasodilating when the heart rate is low. Like for example here where we've got that 54, we could potentially expect to see that drop as a result of the blood pressure, the vasodilation. So we don't want to see that because we may not be able to compensate, we may not be able to push that blood around effectively and lose our cerebral perfusion and things like that. So yeah, it's autonomic dysreflexia is an interesting one. Why it popped into my head while I was eating mango sticky rice is well beyond me. But look, what I'm planning to do now is over the next few days, I'm back on shift tomorrow. No, I've got a day off tomorrow, but it's Sunday, so it'll be a hectic one. What I am planning to do is I'd love to get a video out on the CNS, so sort of looking at the spine and the central nervous system and potentially even peripheral nervous systems. And I'd like to get a much more thorough autonomic dysreflexia video out where we actually go through the signs, symptoms, what treatment pathways are and things like that. We've sort of gone through it here as a bit of a rambling video, but I'd love to get a solid video out there and start getting some resources together and some more resources out there for you guys. So look forward to getting that done very soon, and thanks for watching.